cord, CVA. We only have today's lecture and next week's lecture to get through this material. Chronic neuro has actually been covered in MedSurg 1. I'm giving you a PowerPoint for it. It will be on the final. It will not be on this next exam. But CVA, ICP, and spinal cord will all be on exam 5, which is as soon as we come back from Thanksgiving. Questions on that? Only have 1 more lecture after this.
So our next exam is not so we come back from Thanksgiving.
Right, so we've got the week of Thanksgiving off. That Monday, remember the class is independent, it's online, so it's just to get you caught up. And then when you come back from Thanksgiving, that's when our last exam is, for exam 5. All right, so we're now working in the cognitive perceptual pattern, which is all of your neurological information, and we are going to be dealing with consciousness. So rationality, the ability to think, these are basic human attributes, and this is going to deal with not only the health of the brain, but thought process, knowledge, how the client perceives themselves or how they apply knowledge. So when I look at this functioning, we've got the whole realm of no functioning, basic functioning, up to higher level capacity functioning. So when I'm thinking about normal cognition, the person has to be awake and alert, able to have conscious thought, they're oriented to reality, they can solve problems, perceive sensory input, they respond appropriately when you ask them questions, they can carry out ADLs, and they have a healthy functioning nervous system, all parts of their nervous system. That says I have normal cognition. So anything that I injure the brain or the spinal cord, that is going to impair cognition in some way. So any consequences of cognitive impairment, we're going to be looking for the scope of what is involved with the impairment. Is it affecting ADLs? Is it affecting movement? Is it affecting thought process, sensation, ability to problem solve? Is it causing changes in the level of consciousness? So remember your terminology. What is stuporous? What is lethargic? What is obtunded? What is all those different terminologies for the change in level of consciousness? Make sure that you remember that. When I look at overall risk factors or people at most risk for changes in cognitive impairment, well, the elderly are some of the very first ones that come up. Not only do we have the Alzheimer and dementia and diseases that can cause problems with the neurological system, they are also at higher risk for things like falls and injuries. So you want to think about your risk factors. People who have substance abuse or high risk activities, so these can be your younger people that are increased risk for neurological problems. And then environmental exposure problems, birth injuries, genetic considerations all fall into your risk factors. When I'm recognizing a cognitive, I need to know my neurological assessment. So if you don't really remember those cranial nerves at this point in time, it's time to refresh your memory. All of that neuro assessment, so that, you know, if I put that key in your hand and you don't know that that's a key, what is that test called? Remember those? Maybe look them up. So I'm just giving you an idea of things to refresh your memory on before we really get started with this lecture, because obviously we're not going to finish it today in an hour. So go back and look up your neurological tests. Go back up and look at your tests for your eyes. Besides PERLA, which we have talked about, now we're going to come into, I need to be able to look at my levels of gaze and my other types of cranial nerve tests that also involve the tests for the eye. Your mini mental exams, going back to mental health, that look at the things like memory, reasoning skills, those kinds of things. Make sure that you look those over again. You have the 11 cognitive tasks that were in the mini mental exam. So if you don't remember talking about that in mental health, well, now's a good time to go look it up. Lower the score when you do the mini mental exam, the more severe the impairment is to cognition. Again, we're going to look at level of consciousness. That should already be something that you remember how to do. So when I'm thinking about problems to the neurological system, my biggest two problems that we're going to focus on in this class are going to be cerebral edema problems due to typically injuries for us. And then cerebral ischemia, which is gonna lead to anoxia, I don't have any oxygen getting to the brain, cells are gonna start to die, and if I have cell death in anywhere in the neurological system, we know that it does not heal. The nerve cells never regenerate themselves. So our biggest problem is gonna be decreased oxygen uptake. So just like the cardiac system, you are not getting away from the paired tissue perfusion, because that's for the brain as well. So we are still continuing on with that same diagnosis. Remember when we're looking at behaviors of the person, level of consciousness, we always talk about it as that continuum, and I just told you to know all of those different terminologies associated with it. And we're gonna look at people all the way from being in a coma, so again, remember that Glasgow coma scale, all the way up to somebody who is hyperexcitable with seizures. Now seizures fall into my chronic problems or chronic neurological disorders. So those are things that you're gonna need to pull back from MedSurg 1, you're kind of gonna review on your own. Normal level of alertness is gonna be somewhere in between, and you do need to know that Glasgow coma scale. So if you don't remember it, again, it's here for you. As far as diagnostic testing for the neurological system, so I don't have to go through it with every single disease we talk about. Lab tests are gonna be done, but they're to rule out any underlying medical problems. So there's no specific lab test that we're gonna do for the neurological system itself. They can do neuropsychometric testing, and then our big thing that we're gonna be doing is imaging testing. So brain imaging testing usually starts with an MRI or a CT. The MRI is gonna be most useful to detect things like your tumors, your infarct, vascular dementia, and then any type of frontal lobe atrophy. So those are those are gonna be our main gold standard testing. And then whenever we're talking about neurological problems, especially for the acute problems of increased intracranial pressure and spinal cord injury, this is a multidisciplinary team. Not one person can handle these type of injuries. So we're gonna have the MD, all the different healthcare providers, the nurses, social workers, OT, PT, probably speech therapy, chaplain. I certainly don't have them all listed, but remember this is collaborative. We're always gonna start with management of the underlying problem, and then we're gonna move out to provide general health and comfort, pain management, behavior management, sensory aid, caregiver support. This is gonna be a lifelong, or at least a long-term care of the patient. So we're gonna go from the acute care setting into the rehabilitative setting with somebody with ICP or spinal cord problems. All right, questions kind of on, that's just background information. I'm gonna move into the anatomy patho review. So when I'm looking at all of the nervous system, brain and spinal cord, we know it has protection. So we have the scalp and the skin as our primary protection. We have the vertebral column that's protecting the spinal cord, and then we have the meninges. So how many layers are there with the meninges? 3. Can you name them? Dura mater. Where's that one at? The outer, it attaches to the bone itself, so it is surrounding the bone and the vertebral column, and it actually adheres to the skull. What's the next one? What was it? Well, that's a space, a subarachnoid space, but how about the arachnoid layer itself? It's the middle layer. So the arachnoid layer is named that because it looks like arachnoid, a spider web. It's where all the blood vessels go through. This is the area where all of your supporting cells are found, your glial cells, which are the supporting cells to the nervous system. How many glial cells do we have? How many different kinds? Can you guess? We have 5. We have 5 different glial cells. So in the arachnoid layer, the astrocytes are the ones that are going to be responsible for things like our blood-brain barrier. What does the blood-brain barrier do? It allows what? Does what for the brain?
Amazing what they filters them out, right?
Only allows certain things. What can pass through the blood-brain barrier? Oxygen, that's a good one. Which nutrients What feeds the brain specifically? Glucose. It allows glucose, it allows oxygen. What do we need? Why does anesthesia work on the brain? What can pass through the blood-brain barrier the easiest? Or what can't pass through it? Some medications can't pass through it, but we can anesthetize the brain. Think about what can pass through a cell membrane easiest. What is cell membrane made up of? Lipids. It has a double lipid bilayer, so can fat pass through fat? Yes. The cell keeps water out. The lipids, fat and water don't mix, but fat can pass through fat, right? So anesthesia or things like that can easily slip past the blood-brain barrier. It's like a tongue twister every time I say it, because we attach it to fat, lipids. It's a lipid fat-based drug that will then be able to get into the blood-brain barrier and anesthetize the brain. So again, review some of this material on your pathophysiology of the brain. What was the last layer of the meninges? The pia. The pia matter goes into all the convolutions of the brain. It sits directly on top of the brain and on top of the spinal cord itself. Now the other thing that we have protecting the brain and the spinal cord is going to be the cerebrospinal fluid. Where is that manufactured? It goes around the brain, through the brain, through the spinal cord, around the spinal cord, back up to the brain. How about in the choroid plexus? In the fourth ventricle of the brain. The picture is showing you the choroid plexuses. So these, right here. It's in the fourth ventricle. How many ventricles do we have in our brain? Probably at least 4, since I told you that the fourth ventricle has the choroid plexus. The third ventricle does as well. There's 4 ventricles. They all contain cerebrospinal fluid. Looks like this. So the choroid plexus is there in the middle. It's producing it. You've got some over on the fourth ventricle underneath the cerebellum. It's forcing the fluid out. So what is cerebrospinal fluid actually? When the choroid plexus is making it, what part of it, what is it? Not blood, it's got glucose in it. The plasma portion of the blood. So it is cushioning the brain, and then it is going to go through the subarachnoid space. It goes through the arachnoid, it cushions, and then it returns into the blood via the arachnoid villus into the venous system. So it is constantly being manufactured and then put back in. So when I am looking at the skull and the vertebral column itself, we have a limited amount of space because obviously those bones are not going to move. The only time those bones move is in a baby when their fontanelles aren't closed yet. When we look at the brain and the spinal cord, know all of its parts. You have to know all of the parts of the brain and what they do, because when I have injuries from a stroke, from a intracranial pressure problem, and I'm putting pressure on a certain part of the brain, I'm going to expect you to know what the deficits are that you need to look for. So you need to know what those parts of the brain actually do. So starting with the bottom portion of the brain that attaches to the spinal cord, we have the brain stem. The brain stem has the midbrain, the pons, the medulla oblongata. Each one of these has some specific things that it is responsible for. If we have an injury to the brain stem, what are the things that we need to be most concerned about? Breathing. Our breathing control is in the brain stem, and heart rate control comes from the brain stem. Not as much, it comes from other places, but definitely it's there too. Blood pressure is going to be part of the blood. So some of our main systems to keep us alive are associated with the brain stem. This is looking at a little bit more detailed picture, and then looking at the midbrain. So the midbrain has two big tracts that go through it. It has 4 protrusions. I don't necessarily need you to remember the names, but the midbrain is the biggest responsibility for vision and hearing. It's a reflex center. So everything coming from your eyes and everything coming from your ears has to go through as a reflex with the midbrain. So, and damage to the midbrain in this area can cause problems with vision and hearing. The pons, it's the big bulging part of it. This has mostly fiber tracts running through it. This is where your controlled breathing is located. So damage to the pons can impact breathing. And then the lowest part, which is the medulla oblongata, it's feeding into the spinal cord. It also has lots of fibrous tracts, and it's going to be important to the control of heart rate, blood pressure, breathing. Again, swallowing, vomiting center is also located here. All right. This is attached to the spinal cord. So we know that information has to come from the brain to the spinal cord, out to the body, and back again. We have fibrous tracts, white and gray matter, that help to carry this information. So when I'm looking at the brain, and we're looking at the cell body of the brain, and then the fibrous tract, where is the white matter, where is the gray matter? What makes white matter? What makes it look like it's white? We have a neuron, cell body, and its axon. The myelin sheathing. So in the central nervous system, which cell is responsible for the myelin sheathing? I think we just did this like the oligodendrocyte. The Schwann cell's in the peripheral nervous system. But the oligodendrocyte, big huge cell, wraps entirely around the axon, and it turns it white. So that means the cell body is the gray part. So now tell me, in the brain, where is the gray matter versus the white matter? On the outside. Gray matter. So this is how I think of the brain. Think you're holding a bunch of daisies. The daisies are the cell bodies, and if daisies were gray, they would be the gray matter. All the tracts or the stems going down to the spinal cord are the white matter. They've got the oligodendrocytes wrapped around them. We've got lots and lots of fibrous tracts because we need lots of information carried to and from the brain. But the cell body is where decisions are made. So in the brain, we have stopping points because their brain needs to rethink about what it wants the body to do. So we have stopping points along the way where there are going to be clusters of gray matter where the brain can kind of rethink about what it wants to happen and then send it back out to the body as well. So one of these stopping points along the way is called the reticular formation. This is a diffuse mass of gray matter. It's sitting along the brainstem. So this is a stopping point where the brain can stop before it sends the information down the brainstem out to the body. This is going to be a place that is involved with motor control of the visceral organs, but it also plays a big part in our sleep-wake cycle. So I need you to remember the sleep-wake cycle and the consciousness coming from the reticular formation, because if the damage to my brain, say, is up here at the frontal lobe, and it has damaged cell bodies, and the person is never going to be able to do any rational cognitive thinking, they are never technically going to wake up from an injury. However, if this deep part of the reticular activating system has not been damaged, and it's above the spinal cord, the person can open their eyes, they can have normal reflexes, they can look like they're awake, but they will never actually regain consciousness. Because remember, I said consciousness involves rational thought, alertness, functioning. So this can confuse patients' families because the person can open their eyes. They can have reflexes like hiccups. They can snore. They can yawn. That says the reticular activating system is working, but the higher level functioning from the cell bodies are damaged. So remember the reticular formation, because this will come into play later on when I am talking about the care of a person who is in a vegetative state. So this is looking at the reticular formation primarily. It takes in auditory impulses, it takes in vision impulses, and it's a second stop along the way for the brain to kind of rethink about what it wants to send out to the body. Now, damage to the higher level parts of the brain do not always mean that there is damage to the reticular formation. So you can have independent functioning of these two areas. Is your head hurting yet? It's about that time. Right? This is the slide that you need to know for every part of the brain and what it does. So if you don't remember all the parts of the brain, I'm gonna open this PowerPoint today, so you will have it. This slide gives you everything that you would need to know. So if I have an injury to my frontal lobe, I need to think about intelligence, reasoning, behavior, memory, personality changes. Right versus left side is gonna be important. Our right-sided injuries, remember, with our right CVAs versus our left CVAs. So also take that into consideration. Somebody with an injury to the temporal lobe, speech, behavior, memory, hearing, vision, emotions. When I have an injury to the temporal lobe, other things I need to think about, especially with hearing, it may not be that you can no longer hear, but it leaves them with sensations of fullness in their ears, ringing in their ears, vertigo, all those other changes that can come along with injuries to the hearing centers. The occipital lobe is primarily your vision. So any hit to the back of your head is gonna give you problems with vision, or could potentially give you problems with vision. Remember that if the cells die there, you're going to lose your vision because they do not regenerate. Cerebellum's right underneath it. This is your balance. This is your ability to walk, your muscle control, and your fine dexterity muscle control. So think about, correlate your nervous system tests with the parts of the brain that it's testing. So if I'm doing this, I'm looking at my fine motor control. We talked about the brainstem. Your parietal lobe, which is on the sides again, right versus left. This is primarily where your intelligence and your reasoning, language, Broca's area, Wernicke's area, know all of those different areas and what they do in the brain as well. Okay, so that was just all the background information.
That one section.
This is your background. This is what I expect you to have remembered from AP and Patho. It's a long time ago. That's why I review it again, because it's hard for me to jump right into talking about intracranial pressure problems if you don't understand the parts of the brain and why it's important to know them. Right. When I talk about intracranial pressure, two different things I want you to keep in mind. We always have intracranial pressure modulation going on. That's going to be different than intracranial pressure, or increased intracranial pressure. So first of all, you need to understand how normal intracranial pressure works, and then we'll talk about increased intracranial pressure. So when I'm talking about an increase, that means that there is going to be some mechanism that is going to affect normal intracranial pressure process and function. Make sure that you remember your neurotransmitters and what they do, how the brain regulates itself. Those are probably the two things to know from there. I already talked about people at greatest risk. So when I am thinking about normal intracranial pressure, things that have to happen, I have to have enough perfusion. Perfusion means there has to be enough oxygenated blood going to the brain at all times to keep the cells alive. So remember, the brain has its own special circulation. What is that circulation called in the brain? And that's called the circle of Willis. Remember that? Circling around the brain stem, so that if one part gets clogged, we still can send blood to another part of the brain to try and keep it going. So this circle of Willis is going to be really important to make sure that the brain remains oxygenated. If the brain cells die, lack of oxygen and anoxia causes tissue death, does not regenerate. Now, the other thing that has to happen, we have to have neurotransmission. all of our transmitters need to work, which means all of the axons, their dendrocytes, the transmitters, they have to be working, because one axon goes to the other axon, goes to the other axon. They all have to be intact, and the neurotransmitters have to work. So, if I've damaged a axon or a cell body, number one, now it's not working. If I don't have enough of a neurotransmitter not working. The biggest drugs that affect neurotransmitters are really all those mental health drugs. So that's going all the way back to the mental health drugs that either stop or affect some of the drugs like serotonin and our MAOIs and things of that nature. And then just pathology in general. There can't be anything else in the brain that is taking up space where the blood, the brain tissue, or the spinal cord fluid needs to go. So things like tumors can affect intracranial regulation. We have the three components of the brain that make up intracranial pressure. So brain tissue, blood, cerebrospinal fluid. These are the big components. We know that they're surrounded by bone. The bone is not going to move unless you're a baby. So we have these components that have to sit inside of the skull. Total volume of your skull is about 1,900 milliliters. And the tissue is making up about 78% of that volume, which means that the brain regulates itself to the 100% mark using blood and cerebrospinal fluid. Blood's about 12%, 10% cerebrospinal fluid, and then we have this balance of this 12%, meaning that blood can go up, cerebrospinal fluid has to go down. The volume of the skull tissue or brain tissue itself doesn't really change. It only changes as you age and your brain gets bigger, bigger, bigger. So when cerebrospinal fluid and blood are going on in the brain, they have to be able to go up and down in order to regulate this total volume that's sitting inside of your skull. So think about it as a pendulum, or it's constantly in motion. This is called intracranial regulation. Our factors that are going to influence this: blood pressure, arterial versus venous pressures. Intra-abdominal and intrathoracic pressures influence this. If you sit somebody up, the pressure in your head goes up. If you lay them down, the pressure is going to go down. Your posture: if I stand on my head, pressure in the head goes up. It's just kind of common sense there. Temperature, hot versus cold. Blood gases. We've talked about CO2 levels when we talked about ventilators and how I can have somebody either blow off CO2, or I can have change the respiration rates to retain CO2. If I am hyperventilating, blowing off CO2, it's going to cause vasoconstriction. If I vasoconstrict the capillaries in my brain, what's that do to the volume? Decreases it. So this is going to come into play if I have some